Hi, this is Joe. Doing a voiceover PowerPoint on a 114 slide PowerPoint that we'll be doing on the subject of medications. Now, this one is due September 17th, although I'm expecting that on the 9th, which is Monday, we'll sort of start dancing around the idea of nurses' responsibility for how to do medications, but this one is a major step in understanding what we do and what it's all about because, well, first off, because there's actually an exam based on this exact PowerPoint, so you better study. But then also, this is what nurses do every day, and we have to be thinking about it. Okay, so now here we go. The medication safety exam is divided into two parts. One is how to do medication calculation. The other is nursing implications of medicine delivery, and that's what this one is. So now the thing to know is this is very heavy on the definitions of words. Tried to bold them all, but I couldn't put them all in bold print, but this is one more PowerPoint that probably has 100 very specialized words where it comes to pharmacology and medication. So my advice to you, if you're weak on vocabulary, is to make a vocabulary list, use flashcards, all that stuff. Watch the videos listed elsewhere and we'll see it. When we're talking about drugs and medication, a drug is something that you can take. And it includes illicit drugs, but it also includes things over the counter as well as prescribed drugs. And a medication is something that's specifically told you take it by a doctor usually. And excuse me, one of the confusing things about medications are any given medication can have more than one name due to the history of pharmacology. It might have a scientific name and then it might have a name that everybody knows it by. And an example would be Tylenol. Tylenol is the brand name. Acetaminophen is the name of the drug. They're the same things. Now, you can look all these things up in the drug book, and hopefully before we get to this PowerPoint, we would have looked at how to use the drug book and kind of just as poking through the pages of it. But now this will kind of fill in some gaps. First, just because a medicine has the name on it doesn't mean it's pure or that it came from a reputable source. And what happens is in the USA, there are agencies that regulate the purity of manufacture of these, the USP or the National Formulary. And drug companies are regulated by the federal government Food and Drug Administration as to the standards of purity and quality that they have. Okay, next is, we're going to define this early on because then when we get to it, you'll understand it some more. But there is something called a controlled substance, which is a subset of all medicines. And a controlled substance, to make a long story short, a controlled substance is one in which if the wrong person takes it, it can lead to addiction and or poor judgment due to altered mental status. And for that reason, the federal government or the states police not just who is getting it, but who is administering it and how it's handled throughout the whole time that it is in the hospital, whether it's in the pharmacy or in the drug drawer or being given to the patient. So when we're going to be referring to controlled substances later, have to keep that in mind. They get special documentation and handling as to how they were checked along the way, what was done if there was any left over when you opened up out of the vial, all that kind of thing. And the prototypical controlled substance would be any opiate like morphine, or Valium or whatever. Next is, well, back to continuing on controlled substances. Here's the actual 5 categories. Now, guess what? We are not going to at any time say, oh, this person gets hydrocodone with acetaminophen. Which category of controlled substance is that? Or that kind of thing. But you have to know what's kind of on there. Heroin, LSD, morphine, codeine, diazepam, etc. And that's reading down the left-hand list. As we go through any drugs, when you read the drug book, it will say whether any given drug is a controlled substance or not. Now, here's the next thing is, back still on the whole controlled substance thing. Every hospital or agency that handles controlled substance is going to be required to have very specific policies and procedures as to what the documentation is. And if you divert a controlled substance for your own personal use due to some substance abuse issue that you have, you will come into the view of the law enforcement authorities, which is not something you want to have happen. But anyway, so that's why you have to be aware of that. Now, so we're going to switch around, and we have to make 2 definitions. You won't often see nurses using these 2 words amongst themselves, but when you read up and study up on any given drug, you'll see that they describe the pharmacokinetics or the pharmacodynamics. And these, a lot of times, are important concepts when you're trying to figure out if a person's having a medicine side effect or whether it's working or whatever. Pharmacokinetics includes such things as whether you can swallow it or whether it has to be injected in order to maintain a bloodstream, and how it's metabolized, which is usually either the liver or the kidney. Then pharmacodynamics is the way a medicine interacts with body cells. And for example, certain medicines build up in adipose tissue, fat tissue, and when you first take them, you can't get a good amount of medicine in the bloodstream because they're diverted into fat tissue in the case of an obese person. Consequently, when you stop taking it, it takes a while for the reservoir of medicine to get out of the person's adipose tissue. So that would be a pharmacodynamical. Now, next we have the therapeutic effect, which is the fancy way of saying, what does the medicine do? And this is number 1 thing for when we observe. We are trying to figure out we know what the medicine does theoretically. We want to know how it's working on this specific person, which is why you're going to end up studying all the side effects and intended effects of medicine. And in the long run, during the head-to-toe examination of any patient when you meet them, you would know the typical medicines they're on and check over certain things that go with that medicine. Like, for example, if you know your patient takes Lasix, which is a diuretic that makes them lose fluid volume in their body, we would make a special note to check to see if they were dehydrated, and or later when we get to lab things, what their potassium was. And so the therapeutic effect is something we have to know for every medicine. We never give a medicine unless we know what the medicine does. That's like basic. So now, and these are 4 definitions of things you'll read about in the drug book. And it's absorption, distribution, metabolism, and excretion. And at some point, these can be important looking at some specific patient's response, because there might be some reason that your specific patient isn't responding to these the way you think. Now, there's a few things to know. Is I'm going to skip through this a little bit, but generally speaking, pregnant women, we try not to give them any medications whatsoever, because we want to make sure that any medicine will not harm the fetus. Infants or children require smaller doses. Older adults may metabolize things differently. As far as gender, most medicine studies are done on men, not women. So women might not react the same way to a medicine that a man does. And then cultural factors says herbal medicine. Herbal medicine is growing in popularity in the USA, but if it's herbal, then it's not regulated with the same stringency for what's in the content that, say, an actual medicine would be. So that can sometimes be a problem. If you have a person, especially if they're from a culture known to be using herbal medicine, ask them what they're using and where they get it and all that, because that could be important. I used to live in Honolulu, and we would have people who from Chinese medicine would take black cohosh, which I don't even know what that is, but it's associated with liver failure. So herbal medicines are not without their own side effects. Next is, and we're still on the list of definitions. Half-life of a drug is how long it takes to exit the body. Onset of action is when you take it, how long before it shows any effect. Now, peak and trough plasma levels refer to a lab test that can be done when the person's getting intermittent doses, such as certain kinds of antibiotic, like gentamicin is the typical one. So in pharmacokinetics, sometimes you do have to take frequent lab tests to determine what the blood level of a given medicine is, because it's more likely to have side effects if it exceeds the range of blood level. It might not work if it's lower than the expected range of blood level. So these are a bunch more definitions. This is definition heavy. Now, you need to know the difference between a side effect, an adverse effect, and a toxic effect. A side effect is something that the medicine does that, how would I describe it? The side effect is something that the medicine does. It's not directly related to what the purpose of it is. For example, with Lasix, which makes you pee, a diuretic, the side effect is that it causes your potassium to go low. That's not the same as the medicine effect. The medicine effect is to decrease volume and hopefully to lower the person's blood pressure usually. But then you can be doing fine with the effect, but have a side effect that's unrelated. An adverse effect would be something such as an allergic reaction. A toxic effect is what happens if you get too much of the medicine in your bloodstream and it builds up and starts acting like a poison. So these would be things. Now, I'm trying to think of the first example of a toxic effect is if you overdose someone on morphine or an opiate and they stop breathing. That would be a toxic effect because it will kill them and that's not what we want. Okay, back to some of these adverse effects. If the person is having an allergic reaction, you need to know what the signs and symptoms of an allergic reaction would be, because in order to save the person's life during an allergic reaction, you have to stop giving the drug, start giving very specific drugs to reverse the allergic reaction, usually epinephrine, corticosteroids, antihistamines, and that kind of thing, along with IV fluids, in order to do it. And I should say most often, people who have an allergy will be wearing a medical alert bracelet or something that says what the allergy is. An allergy is so important to know about. It's like one of those things you must always check. A lot of times in a hospital, if you have an allergy and they tell the nurse will put a special band on their wrist right at the name tag saying allergic to penicillin or whatever the drug is, that you basically would notice whenever you were barcoding or checking the ID of the person. That's how important it is to do this. And you have to get in the habit of knowing always to ask about allergies before you give the first dose of any drug that the person is getting. All right, so, and this is sort of like, some of these are in the categories in the drug book, which I hope we already would have gone over, but there's such a thing called an idiosyncratic reaction, which is completely out of the blue, nothing that you expected that the drug would do. Then a lot of times if you give the person a drug, nowadays many people, especially older people, are not just on one or two drugs. They're taking 10 or 15 different drugs, and some of the drugs can cancel out each other or add to each other, and you have to be able to know what the interactions would be and whether they're even compatible. Sometimes if you get a drug, say you're taking a drug that absorbs fluid in the stomach in a certain way, and you're taking another drug like an antibiotic that has to dissolve in the stomach, if you give the two of them together, then the first drug absorbs the antibiotic and it doesn't work. Okay, next we have to define what over-the-counter is, i.e. OTC. And over-the-counter means stuff that you can get at CVS or wherever without a prescription. You go up and down, it says the pain aisle, or the, let's see now, what do they have? The cold and flu aisle, or the constipation aisle. I don't think it usually says constipation aisle, or the laxative aisle. And there's all these choices of things that you can get based on what you think you need. And usually, in order to be allowed to be over the counter, it usually has to be something that's relatively benign. If you overdose yourself on laxatives, it's pretty hard to commit suicide that way, if you think about it. That kind of stuff. But in the meantime, you have to be aware of what over-the-counter medicines the person has been taking. And when you're trying to ask about pills on a given person, ask them what they take, that's, you know, whether they are taking something over the counter. Next, and this is also called non-prescription medicines. The next category of non-prescription medicines is vitamins. And vitamins are dietary supplements, so the production of vitamins are regulated by the FDA, although we'll get into that in a minute now. So on this slide here, what we've got is a list of all the different, many of the different vitamins that people might take. Vitamins are divided into water-soluble and fat-soluble, and the fat-soluble vitamins can actually build up in your person's body. Like I once met a lady who had taken too much vitamin K and her skin turned like orange color, like a carrot. And in the news, there's been this thing about people who do vaping, and vaping is really not as regulated as some other things, but they were doing like not even over the counter, they were buying street vaping cartridges that were available on the street that they didn't really know what the heck was in them. Then it turns out a whole bunch of people died, and when they analyzed what was in the vaping cartridge, somebody added vitamin A to it, and vitamin A is not good to inhale. It's something you can take as a vitamin, but it's like, what's up with that? How did that end up in the person? But I mean, it's just one of those crazy things. Right, so kind of one of the general things about this is there are lots of people who take herbal supplements. When we are talking about herbal supplements, sometimes it's a combination of herbal supplements and you have no idea what exactly is in the herbal capsule that you think they are. And there are many herbs that have properties similar to prescription drugs. For example, if the herb is prepared from the newly sprouted seed of a growing plant, a lot of times the fertile growing plant will have estrogen in it. That's similar to the estrogen that might be part of it's a female hormone, and it might be part of birth control, but it's a potent kind of steroid. So some of these herbs have steroids in them. And like, for example, now, we don't think of beer as an herbal supplement, but in order to get beer, you have to have something called hops, which is a kind of clover, and the best hops are from like springtime hops, as I understand it. And for those of you who are beer drinkers, you can tell how much hops is in a given beer because hops impart a bitter taste to the beer, which some beer drinkers love. Now, one of the things about the bitter taste is it's an indication of steroids in the beer from a biological source. But then if you ever have the opportunity, and I hope you don't, to be taking steroids such as prednisone also has bitter taste. Not quite hoppy, but the cause of the bitter taste is from essentially the same category of organic compounds that you'd find in beer. If you're not a beer drinker, find a beer drinker and ask them about what hoppy beer tastes like. Okay, so now we're still on the herbal exploration of medicines, and this is a table that says different names of herbs on the left, what it might be used for. If someone says, oh, you should be taking ginkgo biloba. And actually, probably 15 years ago, there was this huge marketing thing about ginkgo biloba is a way to stave off Alzheimer's disease. But then for each of these things on the right-hand column, it says, oh, but the marketing commercial doesn't tell you about the side effects of too much stuff. And for that matter, coffee and tea are herbal supplements. They come from a plant, and they're used to make you awake. You can overdose on coffee and tea. Yes, you can. Right, so now, we're going to be talking next about prescription medicines. And as we said, like on day one of class, nurses do not prescribe medicines. And so that means that you can't, if the person says they're having this or that symptom, you investigate it carefully. And if the doctor ordered some medicine for that symptom, fine. But if they have it, you can't just say, oh, take this cough medicine that has codeine in it. No, no, no. That would be administering a prescription medicine without the prescribing ability or a medical license. You can get in trouble. As the saying goes, if you give 2 Tylenol to a patient with a headache, but there's no doctor's order for it, then you have violated the laws of the great state of Florida and every other state. Now, when we have a medication prescription written by a doctor, it has to be very, very clear because there's thousands of possible different medicines and some of the names all sound alike and all that stuff. So it has to have name, when it was started, what the drug is, what the dose is, the route of administration, how often, and then who ordered it. So when we have the prescription, there's a format that the person who prescribes it is expected to follow. Now, after you give it to the person, there's a format that you're expected to use when you record it. And there is something called the MAR. And on this slide it says MAR. MAR is the medication administration record, which can be electronic, like because they'll have electronic systems in the hospital, or it can be done by hand on a piece of special document that your agency uses, which still happens in long-term care. But we have to be able, because of the prevalence of side effects, we have to know what was the doctor's intention and be very specific about what the medicine, the dose was, but then when it was given, who gave it and how did it go and how long is the person on it, because tracking this whole thing about the medicines is a very important responsibility that they have. If the person has a adverse reaction to the medicine, we want to be able to identify the adverse reaction, and part of it is how long were they on it? When did it start and stop? Have they had it before? Who gave it? Was it given properly? All that stuff. So if there's some problem with it, you have to be alert that this is something that we have to deal with and grapple with every day. All right, so next is, nurses do need to know why and how the things get ordered. And also, when you observe the side effects or the effects and you know about the medicine, just because a person is on a medicine doesn't mean they'll always be on it. Sometimes, for example, with high blood pressure medicine, once they're on it, a high blood pressure can only be controlled with the medicine, and the person has to take that medicine until they die. Other times in the hospital, like for example, if you have surgery, the doctor will just give you antibiotics for a week after the surgery, and then you're not on the antibiotics anymore. So now what will happen is when the person is admitted to the hospital or discharged, or especially if they have major surgery, at those times someone reviews the whole list of medicines that they're on and records it and compares it what they're supposed to be on and also what they should be on. So that's something else that you'll be participating in. Now, when we talk about times and frequency and all that, there's different kind of orders of medicine, the doctor or prescriptions of medicine. One is, and this is kind of restating the other one, if the person is getting a heart pill like digoxin and they take it once a day by mouth around breakfast time, that's a routine order. There's something called a PRN order, which is, PRN stands for pro renata, which is a Latin term, although I've heard some people say it stands for per RN. And it's true, the RN decides what to do with it, but a PRN order is one where the doctor will order, say, a laxative, and say, if the person is constipated, give them milk of magnesia, 30 cc's orally times 1. And so that's like, okay, we only give it if the person's constipated, so that means we can either ask them if they are or they'll tell us. Then we see that the order is, then we see if it worked. Now the example is pain medicine, morphine, and that's also true. If the person's not having pain, we don't give it. If they are having pain, we do give it. You'll see something called a one-time order, which is give this person a sedative prior to surgery, 1 hour prior to surgery, only once. In the case of an emergency or a new problem, sometimes the doctor will order what's called a stat order or a now order, which is designed to deal with whatever emergency situation there are, in which the doctor's not waiting for the usual procedure of starting it, starting it the next time that the typical morning orders would be. Give a dose now. We're going to start this. Don't wait until, if it's a once a day medicine, don't wait till tomorrow. Give 1 dose now, and then we'll start routinely every day, for example. Now you're going to see about 50 slides here that reiterate this point. And at some point on a bunch of exams, there will be fill in the blank things that expect you to say, what are the 6 rights of medication? And you have to be able to regurgitate this when someone snaps their fingers, because that's just part of the whole thing. Okay, so now we start off with the routes. And when we're saying the routes, we're saying, how do we get it into the person? Is it oral? Is it put on the skin? Is it IV or whatever? And you can't just simply say, oh, I'm going to change the route of medicine without checking with the doctor, because different medicines, even the same medicine, will have different mode of onset of action based on the route that you gave it. So you have to make sure that you are very much informed as to what that would be. Now we're going to go over each of the possible routes and in detail, so you know how to give each route, or at least have a little bit of guidance. But then the key thing is, like, for example, a person normally takes a bunch of pills by mouth every day. What if they're having nausea and they can't hold down anything that goes in their stomach without throwing it back up? Well, in that case, it doesn't make any sense to give them the pills by mouth, because they won't do any good that way. So how do we choose a different route to still get the pill into the person? This is a big question. Now, the most common route is the oral route, BO. And it's very easy to just get the pill out and have them swallow it. Although, of course, you got to make sure that it did actually get swallowed. So you stand there while they're swallowing it, and you look in their mouth afterward if there's any doubt whatsoever as to whether they are. There's something called sublingual, and in which case it's a tablet that's easily dissolved, and you tell the person to hold it in their mouth under their tongue until it does dissolve. So they have to open their mouth and lift up their tongue while you plop it on there, so that they know where it goes. And you usually have to instruct them how to take sublingual. There's something called the buccal route, and I'm trying to think. I can't remember the last time I gave a medicine via the buccal route, but the idea is it will be absorbed by the mucous membrane of the inner lining of the cheek, and they hold it in their mouth till it dissolves, not on their tongue, but against the inside of their cheek. Next is, there's something called topical medicines. Topical medicine is that is put on the skin or mucous membrane, and a lot of times it's specifically for skin or dermatological problems, although certain topical medicines will be absorbed into the person's body, which we'll go into in a minute. And even if it's only intended to be superficial, a lot of times some portion of it still gets absorbed. So like if the person's getting topical medicines, it's like once every day you slather something on there when you do it. So now I have a picture. This here is a picture of a fentanyl patch. Strictly speaking, I guess this is a transdermal medicine. It's put on topically and it is expected to produce an effect on the entire person's body in terms of pain. But by now we would have had the pain medicine thing. And the thing about fentanyl is if you see one of these patches on there, leave it on there. Because these ones get changed every 3 days, not every 24 hours. Here's a more prototypical topical medicine. For diaper rash or skin breakdown, we would put Desitin over the affected area. This is not a pediatric class. I think at least a few of you have small children at home. Now the thing about one thing about medicine like this is, when you put it on, you don't have to smear it a ½ inch thick. It just has to be enough to cover the area of the body because if you put in a ½ inch thick layer of it, a lot of it ends up in the clothes or the diaper or the bed sheets or something. It doesn't really help the person, so you're just wasting it. And usually if you're going to be applying this, you should also put on a blue glove because your hands will be all greasy when you're done too. And in some cases, if it has medicine in it, you're getting exposed to that medicine in a small dose if you don't put gloves on. And sometimes what happens is you get like a wooden tongue blade and you goop the topical medicine on that and use that to apply it. So that's something to think about. The next is there's inhaled medicine. We'll show you inhalers of different kinds over the next few weeks. When we do oxygen equipment, we'll show you the one in the upper right on top, which is a nebulizer. And then also we'll pass around one of these puffers, which is the meter dose inhaler along with the spacer. So you need to be able to know what they're talking about when they say this or that inhaled medicine for the route. This is usually used if the person has lung problems, especially if they have what we call reactive airway disease like asthma, where there's some irritant on the inside of the lungs that causes wheezing and swelling. And if you give the medicine, then it's usually reverses the wheezing or swelling, and that's the intended effect of. Now we're going to be talking about parenteral routes. When we talked about oral medicines, that is actually called an enteral medicine because it goes into the enteric organs, i.e. esophagus, stomach, duodenum, small intestine, etc. And parenteral means it gets into the person's body but bypasses the digestive system. So when you might hear the term parenteral medicine, and that's what they're referring about. Now the tricky part about parenteral medicine, and there's more than one route, but the effect of these is much more immediate than if you took the medicine orally. And we'll talk about this more, but with certain medicines, if you give them into the vein intravenously, you will start seeing the effect of the medicine within 15 seconds of administration, which is different than if you gave the exact same or similar preparation of the same medicine via a pill. Sometimes you can give a pill to a person and it doesn't really work for half an hour or an hour, but then you can give that same medicine to the person and 15 seconds later it's there. This is one of the reasons why beginner nursing students are never allowed to give IV medicines ever, ever, ever. Because if you're not good at observing medicine side effects, if the medicine side effect happened within 15 seconds of administrations, that means you might be getting toxic dose of a medicine and not even be able to recognize what's happening. So it's important to be able to develop observation skill of regular meds before we start giving IV meds. Now we're going to have a whole special lab in which we handle all the medicine administration equipment. But when one of the things will be how we use a sterile syringe, and a sterile syringe has different parts to it that have specific names, very similar to the way any tool or that your automobile would have, or an engine, or for that matter, a handgun. And so we'll see this and we'll be talking about what is the names of the parts of a syringe. Next is, when we're on specific to talking about parenteral medicines, if it's a subcutaneous, intramuscular, or IV medicine, means that in order to deliver it to where it's supposed to go, we have to pierce the skin using a needle and squirt the medicine into the person via that needle. Now, this is going to be something you need to memorize in the long run. Needles are categorized according to the length and the size. So the length is in inches, and then the size usually uses what's called a gauge. And the typical needle for subcutaneous is small, like 25 gauge. And the typical needle for an IV is going to be a 21 or a 22. On the left-hand side of this, you'll see an 18 gauge. A lot of times they'll have those out in the medicine preparation room because sometimes in preparing the medicine, you have to transfer it from one vial to another, and it's easier when you have a bigger needle to do that with. You would never give a shot to a person with an 18 gauge needle. And the thing about it is this: the doctor will write a very detailed description of the prescription, but the nurse is expected to know which needle they will deliver it with and choose. And like if you have a person who has insulin, who gets an insulin pen, the fancy needles for those are like a 31 gauge needle, which is really small and practically like a mosquito needle, and hurts less. Now, one of the things you're going to be expected to be able to do this semester is to name which needle you choose for certain different kinds of situations. So, and we'll talk about that. We'll actually pass them around and you'll get to actually physically see them and all that. But if you're not aware of the idea that you have to be the one who knows enough about needles to choose the right equipment, well, now you know. Now, here's a more specific way of looking at it. I showed you the picture a minute ago, but if the doctor specifies sub-Q, intradermal, intramuscular, or intravenous, then you get to be the one who picks the syringe, you get to be the one who picks the needle, and you also get to be the one who picks the site in which it's going to be injected. So learning the needle sizes, learning how you would decide which syringe, and then also being very specific about your strategy for which site you will use is all part of it. And we'll go into the site selections more in a bit. So now, There's something called a filter needle, which filters out microscopic particulate matter from the medicine. And you need to know when those are used. Like, for example, if it's in an ampule, which is a glass thing, when you break the ampule, very small microscopic shards of glass get mixed in the medicine. You don't want to inject those, so use a filter needle when you're drawing them up. Now, the next thing is there's something called a needleless delivery system. I'm so old, I remember before needleless delivery systems, where we really used a lot more we use more metal needles to hook up IVs and things than we really needed to. That meant when you threw them away, you had a lot more needles in the trash, and people could accidentally stick themselves if they didn't handle the trash properly. So that's a no-no due to bloodborne pathogens. But then the next thing is, even with a needleless device, you still dispose of the trash the same way you would if there was a needle, because even with a needleless device, you can still have the patient's blood on them. Okay, so now, the next thing here is this. We will be studying and practicing all aspects of handling medicines. By the time we actually get to the lab where we do this, everyone's usually pretty hyped up saying, oh my God, I've always known this is what nurses do. I'm going to give a shot to a patient. And because people visualize, they say, what does a nurse do? They say, oh, the nurse gives the patient pain shots. Well, we don't use as many shots as we used to. We give more things through the IV, but we still are in charge of giving medicines to whoever we're there if they can't take them themselves and all this. So there's a lot that goes into medicine. Just because the doctor ordered the medicine does not mean we go give it all the time without checking the patient. We have our own responsibilities. There might be some reason why the doctor ordered a medicine for some valid reason, but then things have changed. Like, for example, if they're in a broad spectrum antibiotic for 4 days and then they develop C. diff diarrhea, then that's time to reevaluate which antibiotic the person is getting. And the nurse is the one who checks to see if they have C. diff and calls up the doctor and says, oh, your guy's been on antibiotics for 5 days and now they have C. diff. Now what do we do? So now we do have to only follow written orders in order to make sure we have the track of that. Next here is, and I laugh when we do this, and I think the next slide is about handwriting. I am so old, I predate the use of computers in healthcare, and certainly predate the use of computerized physician order entry, where everything is legible because it's essentially typed out or data entered. People would do all this by hand, and that meant that reading the written order was an art all into itself. And the idea that if the doctor was in a hurry when they were writing, their handwriting might not be legible. And this is like a whole genre of jokes about illegible physician handwriting, but it is and was true that physicians of a certain generation were famous for sloppy handwriting or for distinctive individual handwriting. So what would happen would be, we would sometimes say, the doctor would write something out and you would read it and you'd say, I don't know what this is. And then you'd get another nurse to read it and say, oh, you're familiar with Dr. Renfrew's handwriting. What does this mean? And the nurse would say, oh, it means blah, 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 blah. Or else it's like, I can't understand it either. Then you'd call the doctor and say, what did you order? Or in the old days, they would write it down, and before they left, they had to read to you the orders that they had written to make sure that there were no questions. So part of the thing is, When you read the order, you have to decide for yourself if that meets all the rules for a correct order that was backed by about 10 slides. Now here's an example of what we're speaking about. Here's an old-time example of a prescription. It actually says the date on there, 6/23/05. Well, that isn't that old. But here's 3 medicines on there. Ferrous sulfate 300, that's an easy one. Humulin N, 30 units, SQ, QAM, that's the one on the bottom, that's an easy one. But what does that first one mean right below address and above no refills? Well, the place where I got this off the website said what that was supposed to be was Isordil 20 mgs PO Q6 hours. But then if you didn't know that it was Isordil, it's like, how the heck did they come up with that? There's another medicine called Zestril, and there might even be one called Zendril. And it's like, how do we know for sure it's not Zestril or some other thing? And does that look like Isordil to you? And the answer is no. That used to be a way that medicine errors would be made. The doctor partly writes it out, scratches out something, and says, oh yeah, they'll understand it. No, they won't. So anyway, next is, you need to be familiar with how to do the MAR and what the vital signs are. Now, there's 2 kinds of MARs out there. One is what's on the Pyxis machine, which is an electronic touchscreen that you can use to look to get medicines. And somewhere on there is a video about a little bit of an introduction to Pyxis. PYXIS is the brand name of the company. And it's all medicine supply chain management. But how that requires a specific documentation system. But then you might have these little sort of cardboardy documents that are used when you have blister pack and long-term care. Now, the next thing about administering any medicine is you must be aware of what the recent vital signs were. We already talked about this, saying if they're on a heart pill, we take the pulse apically for a full minute. If they're on a blood pressure pill, you take the blood pressure before you give it. If they're on morphine, we check the respiratory rate and pulse ox before we give it. That kind of thing. Because what happens is this. We want to make sure that we don't create a medication error and in judgment, meaning that we do every possible thing to give medicine safely. And there is such a thing as a medication error. And it can happen anywhere along the way, and we need to prevent these errors from happening. Now, this book, I have a personal copy of this in my office because this resonates with me. I don't know if you recall which movie this comes from. Dark Arts Defense, Basics for Beginners. But this is a textbook from Hogwarts Academy, the place where Harry Potter and Hermione, I forget the name of the other characters, all went to learn how to be wizards. What they were doing was they were learning about bad spells, bad things that can happen. How do you prevent yourself from becoming a victim of an evil spell cast upon you by a wizard that does not have best intentions toward you. And one of the things that we're going to be talking about, and so the reason I mention it is this. We do have to tell you how you do medicines, but because there is so much emphasis on preventing medicine errors, we do have to be very clear about telling you how not to do medicines. Normally in nursing education, there will be people who say, oh, if you teach the students what not to do, that confuses them. Just focus on what to do. That's not what I believe. I will go out of my way to tell you, don't do this. Don't do it that way when I'm telling you how to do something. Because skills performance is partly what you do, and it's also using the best technique, which means partly what you don't do. Okay, so there are a variety of medicine errors, and we'll spend a lot of time talking about these. But one of the things is, as soon as you determine that a medicine error has been made, the first thing you must do is to protect the patient from adverse effects of that medicine error, which means notifying the doctor and examining the patient again and doing what the doctor tells you you need to do. Now, as I said before, we have what's called the computerized order entry system and barcode system that prevent a lot of medicine errors from happening, but they're not the only parts. And we'll have to make sure that you're aware of how we find a computer order for a medicine and how you actually use the barcode scanner, just like at the checkout counter at the bedside when you're giving these medicines. Now, there's two things on this slide. One is the picture, which is a row of slices of Swiss cheese. I don't know about you, but I love Swiss cheese. And Swiss cheese is the kind of cheese that has the holes in it. And if you slice it, one of the things that will happen is, as long as the slices stay in order, the holes don't go all the way through the cheese. So if you decide that you were going to hang up the cheese by sticking them on like a barbecue skewer, you would find you have to line up the holes. When we are talking about medication safety, there's a whole series of systems in place to prevent medication errors. And 99% of them have already been prevented before you even get on duty. But you do have to be aware of what those are. This is called the Swiss cheese effect of fail-safe mechanism after fail-safe mechanism, or what's called idiot-proofing medication delivery, which means making it so easy that a fatigued nurse will give the medicine properly at 4 o'clock in the morning after they've been having a busy shift and they're dog tired. Now, the other part of this slide is talking about sentinel events. And you do need to know that sometimes the medication error can be so bad that it does kill the person. The person dies because of the medication error. And what happens then is that's called a sentinel event, because death of a patient is the worst possible adverse outcome you can have. And that's the kind of thing that makes the newspapers. And like an example, a classic sentinel event is person goes into the hospital because they need to have their left leg amputated. They go to surgery and they wake up and realize their left leg is still there, but the surgical team amputated the right leg. Wrong site surgery is like a thing of sentinel events. But another sentinel event would be giving a dose of penicillin to a person who has penicillin allergy and previously had a full-blown anaphylactic reaction, and then they die with this new dose. Someone should have known enough to check about the allergies, but obviously didn't. Those are examples of the worst possible kind of sentinel events. So when we're talking about the defense against the dark arts, we want to prevent something that's obviously stupid. So next is, one of the issues for medicine is going to be actual calculating the dose. Now in the hospital, you're going to find that the majority of medicines are actually ordered to what's called the unit dose system. When you go to get the medicine for your patient, The dose that is available to you will mostly always be the dose that was ordered in its own container. So we've already taken big steps not to need to do last minute handling of the medicine that alters the dose to the largest degree possible, but sometimes you have to recheck what the dose was, or you still have to double check to make sure that the dose is what it is. Now, in the olden days, before we had what's called the unit dose system, what would happen would be it was much more important to know how to do dosage calculation. And it still is important when we're drawing up sub-Q, IM, or IV medicines. But we do it less than we previously did. Now, the thing you need to know is you cannot pass this course unless you can pass the drug calculation quiz. And because that's how important it is to be able to do dosage calculation. That's the bad news. Now, the good news is you get 3 tries at the quiz after each go round if you don't get it, and we'll coach you. But dosage calculation is a big piece of what we do. And essentially throughout nursing school, there's a rule that says there will be 2 dosage calculation questions on every exam once you get to this point of fundamentals. So now back to the slide where it says metric, apothecary, and household. Metric system is in universal use these days 99% of the time. So you have to know how to do metric stuff, and somewhere I have a handout on metric system which I'll give to you, and then there's the metric song and every other thing. You can still make medicine errors with the metric system. For example, if the medicine is supposed to be 0.1 milligrams, but then you put down 0.10 milligrams, if the person reading it doesn't see the little decimal point, they give 10 milligrams. Don't do that. We never do a trailing 0 after a medicine. Now, we used to have the apothecary system where we would say the minim and the grain and that kind of stuff. Every now and then with aspirin has been around a long time. A grain is actually 60, 64, 65 milligrams. And sometimes, even with younger doctors, they'll say 10 grains of aspirin for a headache, which is 600 milligrams. And which means it usually comes in 300 milligrams a capsule, so that means 2 aspirin. And you might see that as grain X, 10 grains in Roman numeral system. And that still is used sometimes. Now, related to that, one of the exercises I should have you do is to go down to CVS and just look at typical medicines that you might see, like for constipation or diarrhea or cold medicine, and just kind of read the labels to get an idea what the typical doses of some of these drugs are. And we have a special game we'll play in class. Now, there's also the household system, which is stuff like tablespoons, teaspoons, drops, ounces, that kind of thing. Now, this next slide is still about dosage calculation, and you have to be able to apply a formula for how to do dosage calculation. There are dimensional analysis and ratio proportions, etc. When you get if you get a medicine calculation book, they will always go into pediatric drug dose calculation and or body surface area calculation or IV drip calculation or IV calculation. Now, this semester we are focusing on calculation of oral drugs, subcutaneous, and intramuscular drugs. And we are not doing pediatric or body surface area or IV drug calculations, period. That will be for a future semester. But you have to know how to do it. Now, typically, you always have what was ordered and what's available. So, like, for example, doctor says 600 milligrams of aspirin. You pick up the aspirin bottle, and it says each tablet is 300 milligrams. And the question is, how many tablets do we give? I'm going to give you a little minute to think about it. You have 300 milligram tablets, but the doctor wants the patient to get a total of 600 milligrams. How many tablets? Right, hopefully you should have come up with the answer, which is 2 tablets. Was that so hard? But yet, there's typical. That's a relatively easy one. But then, like if we're drawing up a liquid to give as a shot to a person, it gets a little more complicated. Now, this slide here kind of goes through some of the steps, and I'm not really going to give examples of this. Here's my take on this. It's like, got 29 people in the class, probably 26 of you can already do this without extra coaching. So you should kind of review it, then take the quiz, and then maybe there will be 2 or 3 who need to go the second time or whatever. When we do it in class, why should I spend 3 hours going over this laboriously when most people can already do it? So the idea here is I don't spend a whole lot of time in class doing this. You need to identify yourself whether you can do it and get help. We will get the SNA to come help us do it for those persons who want to work through more problems or whatever, but it's just not, it's an arithmetic, algebraic, mathematical skill that's not the best use of actual class time. But we identify the label, make the equation, convert units, cross off labels, numerator and denominator. Dun, da, da, da. Now, we always do the 6 steps, and we always carefully make sure that we are looking at the record and reading it a couple times. There's studies that have been shown that when you're doing this, you should not be interrupted because it takes concentration. And actually, there's some hospitals where if you're giving a medicine, you wear a special vest like a Walmart vest, and that's meant to be a signal to everybody else not to bother you when you're giving medicines. Now, at a prior clinical site where I always supervise students giving medicines, I had a rule which says that if I was with one specific student giving a medicine and other students were around and they saw that I was standing right there but they had a question, they used to come up and interrupt me and ask me this or that question. I had a rule which is, if I'm with that student, I'm not going to answer your questions. Don't even come within 10 feet of me because I can't help you. Go get the staff nurse. That's how seriously we take this because getting distracted, this is like texting while driving. You don't want to text while driving because you'll get in an accident. Same thing here. You don't want to have 3 multitasking conversations while you're trying to do a medicine calculation because that is not going to be helpful. Okay, so then when we get the medicines, you don't document them until after you gave them. Now this is where we're going to be going. They do have the barcode system. You can't even give them to the person until you scan them with the barcode. And then when the person gets it, then you scan it again because you're standing right there. Very easy to follow that rule. And then this other, used to be you had to go to the med room, get the pill, give it to the patient, then go back to the med room and chart it. So it's much easier if we have everything by the bedside. If you have paper charting, there are very specific documentation rules that have to be followed. Okay, next this slide says computerized charting or whatever, and usually computerized charting nowadays means the barcode system at Lakeland anyway. You have a barcode thing in every room. Every individual pill is individually wrapped and it's got a barcode on the wrapper. And you barcode the patient's barcode from their ID band, then you barcode the individual medicine on the wrapper and discuss it with the person and put it into the cup. So it's kind of hard not to documentation. That system makes it very easy to make sure it's properly documented. If the medicine comes up and it's not on the barcode, that's a sign that first you won't be able to get it out of the machine. But then second, maybe there's a medicine error. Don't give the medicine. That kind of thing. Now, I want to say that there is a group called the Institute for Safe Medication Practices, and I got the web link right here. Used to be they had a free newsletter just for nurses. That was kind of your monthly reminder. Actually, it was every 3 months. Your quarterly reminder of safe medicine practices. It used to be free, and then it turns out then they decided they would be better if they charged you for a subscription to it, which is expensive. But you should go to your site and browse around. When you're working at a hospital, what will always happen is there will be updates. We're doing a new medicine. Here's the safety. We're changing the way we always give an old medicine, and here's what we have to do now. So the group learns how to do a policy and procedure at the same time. So you're still doing adult learning while you go. There's an awful lot of medicine since I started nursing practice that are either obsolete now or where we understand it better and we don't do it the same way we used to. Now we have a quick quiz here. If you're having a problem with a medication order, especially a written order, what's the best action? Did you pick out your one? All right, next quiz. Now, this is a big list of things you need to do. If you follow them, these are safe practices, so they should be your customary practices. And you got to get in the habit of always doing these. And you'll see nurses who always have a way of doing this. And including if the person's conscious, discussing the medicine with them before you give it. You know, they're on a laxative. Well, how was your bowels? If the person says, oh, I've been having diarrhea. Well, then don't give the laxative because diarrhea is too much laxative. That kind of thing. Next thing here is another one here. This goes back to something we already said. Anyway. Now, we're going into this next whole bunch of slides talks about ADPIE. How do we apply the nursing process to the medication process? So I think there's something like 40 slides here that talk about ADPI as part of this whole deal. And so we're a bunch of things about assessment. And the idea is baseline assessment and medication-specific assessment. So this means you need to know the effects, side effects, and reactions to each of the medicines the person might be getting, because you're going to check them for each one, which, like I said before, don't ever give a medicine unless you know what it does. And both Cindy and I have an ironclad rule, which is if you're giving the medicine or even if we're not giving the medicine, but we know what the person is on, we will ask you to describe in 5 words or less, oh, what does this medicine do? What did you check if this person is on it? Like, for example, if the person is on a high blood pressure medicine, what do we check? We check the BP before we give it. All right, so next here is, some medicines are associated with changes in lab results that require periodic blood testing. This is a list of things that you could send down for labs that have something to do with what medicines a person's on. Next is, we will incorporate our knowledge of the medicines based on when we're reading up on them, what it tells us we should check, and then also the vital signs. Now, this here is a very, very important slide because there's a beginner mistake everybody makes. Deep within your heart, I know you don't want to make mistakes. I know you're a good person. I know you have the best intentions for your patient, and they're honorable and lofty and noble. But when you're looking up, what we'll do is we'll actually have you look up your medicines and jot down a few things so that you can remember what they do. Ultimately, you memorize a bunch of meds, but while you're in the process, it'll say something like, check the vital signs before you give this medicine. Now, here's the thing is, we don't just give the vital signs, then give the medicine and record the vital signs. When we check the vital signs, there will be something that we're looking for that will tell us not to give the medicine, and those are called the parameters. And sometimes the doctor will write out the parameter in the doctor's order, but then sometimes the doctor expects you to use common sense to determine what the parameters are. And like, for example, we already said if the person has a heart pill, we check the pulse beforehand, and we do it apically for a full minute. That's reasonable and what have you, but the question is, what are we checking it for? And the answer is, if it's too slow or too fast, we want to check with the doctor again. And so sometimes the doctor will say, give digoxin or low pressor. Hold if apical pulse is less than 60 per minute. But you should know that even if they don't specify it, 60 is the lower cutoff. Like, for example, respirations less than 10. If the person received morphine 15 minutes ago, and now they have respirations of 6 per minute, that means that's too low. If they're on any blood pressure pill for high blood pressure, you check the blood pressure beforehand, but if their top number is 90, that means they're getting too much of a good thing. And you should not give the pill and check with the doctor to see what they want you to do. Because if they're on a blood pressure pill because their blood pressure is 160 by 100, but then you take it and it's 90 by 60, if you give that next dose of that pill, you know what's going to happen? Their blood pressure is going to be 60 for the top number, and they won't even be able to raise their head off the bed without fainting because they'll have such awful postural hypotension. That kind of thing. So that's when people are submitting their care plans and they include lists of drugs, I will always expect that you write down what were the when we take the vital signs prior to this drug, what are we looking for that might indicate to us that we don't give the drug. All right, next is, if the person is on oral medicine, we have to decide if they can swallow. And for that matter, we have to decide if they're taking oral things. Let's say They're going to be having surgery, and the doctor said, do not eat or drink anything for 8 hours prior to surgery. Well, does that include the meds or not? That's the thing. But even if they can eat or drink, can they swallow a pill? If they can't swallow the pill, you might have to crush it. Or a lot of times people will mix it with applesauce to make sure that they can swallow it okay. And for that matter, sometimes people take a whole cup full of pills and they chug them down with no water. But then you might meet people who have to take one pill at a time and taking a sip of water after every single one, because that's how they take pills. By the same token, when we're giving a medicine via a shot into a muscle, if the person is really thin, like a cancer victim, and they have very, very skinny muscles, and they might need more than one shot, it's not a good idea to use that route, because that'll hurt the few muscles they have left. If it's an IV medicine, we have to make sure we have an IV in a good vein. And for any topical medicine, we look at what the skin looks like. Now, so we're on ADPI, and on this one, we're on nursing diagnosis. And there, I can think of 50 possible nursing diagnoses that go with medicines. But here's 3 common ones, which is deficient knowledge. You need to know what the med does, but does the patient know what they need? Does the patient know what it does? That's always fascinating to find out. Constipation is another one. Constipation is a side effect of morphine use or any opiate. Never give an opiate without asking the person when they move their bowels. Now, the next thing here is a nursing diagnosis of non-compliance. Now, we'll talk more about the non-compliant label. There will be people who don't want to take their medicines even though they need those medicines, and they make a conscious decision not to take them. We call them non-compliant. They may have a very good reason for not doing it, and you can't just lightly say, oh, you're being a jerk by not taking the medicines the doctor wants you to have. That sets us up for an argument, and what's the purpose of that? We have to be able to figure out how we'll help them understand what they need to do, or find some solution that's acceptable to the patient that meets the goals the doctor might have for that patient. So next here is planning. When we decide that there's an actual nursing diagnosis associated with a given medicine, such as deficient knowledge, then we plan out how will we teach them, what we'll remind them of, stuff. Then ADPI includes implementation and evaluation. So some of this is duplicating what we said earlier, but the implementation is you get the doctor's orders, use the 6 rights, and for each route you use the best known available policy and procedure for how to do it. For oral medicines, we assess the ability to swallow. We make sure the person did swallow it. We use special techniques if they're having big pills. And one thing to know is certain medicines will be called enteric coated. And if they are enteric coated, they should not be crushed, which is a little factoid we'll get to later. There will be, for oral medicines, sometimes the person will be on a liquid medicine. And liquid medicines come in their own pre-measured packet. Like if you get a condiment at, I don't know, McDonald's or somewhere, a lot of times it'll have a pre-measured amount of one of the condiments in this small package. Actual liquid medicines come that way too. When you actually have, if you only use a partial dose of such thing, you don't save it. You throw away what's left over. Now, sometimes you'll see medicine given through a nasogastric tube if the person's GI tract is intact, but they can't swallow. In that case, they crush them and they put them and they dissolve them and then kind of administer them through a small funnel into the end of the tube. And that requires, there's actually a video on how to crush meds somewhere on the calendar. Next is a few considerations. This is reviewing the different routes. So this is for sublingual or buccal medicines. You don't want to touch them. If you're wear a glove. If you actually have to place the medicine in the person's mouth, don't reach in their mouth with your bare hands. Put a glove on and hands away. Topical medicines says clean the skin, clean the old dose off. Use gloves or applicators so that you don't get any of it on your own finger. Oh, now I should have had this earlier in the slide thing. Here's a typical topical medicine that's used with newborns for diaper rash. Smear it on the affected areas under the diaper and it protects this barrier effect. We do actually have barrier creams that we can use for adult patients that are incontinent to protect their skin as well. And right now I'm blanking on the name. There's two kinds that people always use. I can't remember the name of either of them right now. We'll get to that. If there's a CNA in the house that can remind me, let me know. When we have a topical medicine, a lot of times it'll be because of some kind of skin rash. We note, where is the skin rash? Is it better than it was yesterday? Is the medicine working? Is it worse than it was? How does that work? Next is, there's transdermal medicines, which I think we already kind of talked about. Some medicines will be done, and like one is the nicotine patch. And they had TV commercials for the patch. Back along, get the patch. If you have a person who's a real nicotine addict, sometimes they'll go crazy with their nicotine withdrawal. And you can call up the doctor and say, hey, listen, this guy normally smokes 2 packs a day. He's having anxiety attacks and he's thinking of signing out of the hospital. What about getting him the nicotine patch? And then the doctor says, oh, that's a good idea. I'm glad I thought of it. Then you get the order and then that helps the person calm down. Now back to this one here. Here's an example of a transdermal medicine. If the person's got one of these, don't take it off just like when you're bathing them. If you're getting a new one on, like the fentanyl patch is going to last for 3 days. So that means they'll get a couple of baths in between there. Always put them in the same place. And typically fentanyl goes on the back, on the upper part of the area between the shoulder blades, where it's harder for the patient to reach them. And every 3 days you put a new one on, so that means you have to take the old one off and dispose of it properly. And one of the videos is, what is the proper way to do fentanyl patches? So go see that video. All right, next is, there are ophthalmic medicines, which is the route of giving eye drops. And there's 2 different kinds. One is, if you give eye drops, don't actually touch the dropper to the patient's eye because that'll contaminate it. But there's more than one kind of eye drops. First, in some cases, the eye drops are meant to dilate the pupil and release the pressure. If that happens when you drop them on there, you don't actually drop them on the pupil, you drop them on the white of the eye. But there's this interesting thing, which is, if it's a pupil dilating eye drop, it means it will have autonomic nervous system effects. And you need to know that it can get absorbed in the whole rest of the body. And the way that that happens is through the tear duct that empties from your eye into the nose. So there is something called the lacrimal duct. Oh, what is the other name for this? The inner canthus of the eye. There's a medical term for this which you would never use to a patient because it's too confusing. But basically, if you give the person the certain kinds of eye drops, you should pinch the bridge of their nose to prevent them from just going down into their nose and tear duct. That's one thing. Next is certain other kind of eye drops, such for example, an eye ointment that might be used if the person has had cataract surgery and has the lens in place. You don't put that over the pupil of the eye either. You kind of pull down on the lower lid to expose more of the white eye of the eye. I can't remember if I got a slide on that or not. But so you have to figure out what is the best way to do it. And a typical problem with eye drops is the eye drops end up on the patient's eyelash and not in the eye. The eyelashes are a protective thing for the eye. And you have to get on the other side of the eyelashes to make sure it goes in the person's eye. Okay, so this is saying make sure you have 6 rights. If the person gets eye drops, this is going to seem weird, but sometimes they'll have different eye drops for the left eye than they do for the right eye. So you have to be clear about which eye it goes into, or both, or now. Here we go with the dark arts. And if you ever see this on any place where we work, come and get your faculty immediately, because this is a big no-no. And let me tell you the story of this. If a person has blood in the stool that's kind of digested, it's not going to be obvious blood. So there's a bedside test you can do called testing for occult blood, in which you put this developing solution on a smear of it and it turns a certain color. Now the solution is made of hydrogen peroxide. I think it's 3%. This is what the developing solution looks like. Now, you wouldn't believe anybody would be this dumb, but it looks like an eyedropper container. And on more than one past occasion, somewhere in this great land of ours, somebody has reached for the eye drops, and either they weren't paying attention or they didn't read it, and instead of grabbing the eye drop thing that has the patient's name on it and doing the 6 rights, they pull this out of the medicine drawer and drop it into the person's eye, which will cause immediate pain and burning, and which can actually develop long-term scarring of the cornea. And now, doesn't that sound awful? It should. So now here's what happens. There's a rule from the Joint Commission of Hospitals that says Hemoccult developers should never be kept in the medicine room and should not be available on the nurse's ward, because of the danger that somebody will mistake it for eye drops. So if you ever actually see this in the medicine ward, on the cart, if they use a cart system, or in the medicine room, if they have a medicine room, it's like, tell Cindy or me, and we'll find them and tell them, this is a no-no, which everybody knows anyway. But like, this is an example. You get a medicine and you think you're reaching for the right medicine because it kind of looks like that. If you get sloppy and you don't actually read the label, this is an example of a mistake. Now, you would think that this is such a dumb mistake. Who would possibly do it? And yet, somebody did somewhere along the way, more than one time, more than one location, different nurses involved. So, like, that's an example. Now, there are eardrops. We'll tell you about eardrops if the person has whatever. If you're giving eardrops, make sure you do the rights. Some people will get nasal medicines like, I want to say Visine, but that ain't it. Afrin nasal spray to prevent nasal congestion. And the thing is, there's procedures for how to do this. We'll do all the 6 to give nasal spray. Now, we sort of showed a picture of inhaled medicines back along when we were saying there's meter dose inhalers, which are handheld, and there's also nebulizers, which are hooked up to a gas source, and they kind of produce a smoke kind of thing that the person inhales. So if the person is getting a nebulizer, we check their breath sounds and pulse ox and pulse before and after the treatment to see if it improved things. And that would be one thing we do. So we'll show you how to do nebulizers at a future date in the class. Now, there are such things as vaginal medications of various kinds. Or for that matter, if the woman is having their menses, using a applicator for a tampon, those require different things. Most often, if you're in the hospital setting and you have a younger woman who's not postmenopausal who needs this, people usually will use whatever system they use at home. And it would be unusual for you to have to help them with their menstrual supplies. I don't know what to say. I usually hand that over to the lady nurses to deal with. Then rectal medicines. Now, rectal medicines can be used if the person cannot take PO. When we do it, we put a glove on. We still do the 6 rites. A lot of rectal medicines come in some sort of waxy thing that dissolves when they get up to body heat. So they're refrigerated. Then when you get them out of the refrigerator, get them into the person before they warm up. And then have the person hold on to them until until it dissolves. Make sure you unwrap it, and then it has to, when you put a rectal medicine in, you have to go far enough. There's something called the internal anal sphincter. You just don't put it in a 1/4 inch and call it good. You have to pretty much reach your whole finger in there. And there's a certain point where it gets past the inner anal sphincter, it kind of floats away out of touch. All that. Always use the 6 rites for rectal administration. That would be good. Now, next thing we're coming up to is actual administration of parenteral medications. And we're going to spend about a 3-hour lab doing this. And this is described in detail in Pearson Volume 3. So I kind of will go over the high points about nursing considerations, and we'll also end up covering it in lab. And it's a psychomotor skill. You'll practice this, and you'll watch others do it. Because you're breaking the skin, and which is an important part of the chain of infection, we have to use aseptic technique, and we have to use sterile technique for the medicine so that we're not injecting bacteria below the skin along with the medicine. And because these medicines act much faster than oral medicines, we have to become expert at observing the patient for medication responses when we use these routes. Then we have to properly choose the equipment. We have to observe safety requirements so that no one gets punctured with a needle that has blood on it after it's been used on a patient who may or may not have hepatitis or HIV disease. Okay, so parenteral medicines include things that come in either vials or ampules. And on the right, this says an ampule and a vial. The caption of this is exactly opposite. The vial is on the left and the ampule is on the right. A vial is a plastic or glass container holding more than 1 dose. Sometimes what happens is you get the vial and the medicine is in powdered form, and you have to add liquid to dissolve it, and that's referred to as reconstituting the liquid. And if it requires reconstituting, that's a whole different set of rules for how to prepare the medicine, which we will have to go with you as the occasion arises. We frequently reconstitute antibiotics, but those are also more often given intravenously, so we'll deal with that probably more in a future semester. Now you can have a pre-filled cartridge or a pre-filled syringe and which the pharmacy supplies it, and you don't have to measure it or whatever. That makes life easier. There's rules about parenteral medicines, especially IM. Sometimes the doctor will order a combination of 2 different medicines, and if you're not clever, you'll say, oh golly, that means 2 different IM shots, and then the patient will be there saying, why are you giving me 2 shots at the same time? And certain medicines can be mixed, so you only give 1 shot, others cannot. Next is, now here is a handy little thing that tells the difference between different kinds of injections. On the left says IM. Usually IM injection goes straight in and it goes deep so that it is administered into the muscle, which is red and more vascular. And an IM injection will work more rapidly than the other ones on this page because it is delivered more closely in approximation to the bloodstream of the recipient. Then there's subcutaneous meds, and subcutaneous means you're putting it in through the skin into the fat tissue, and you'll notice that one is at an angle and the other one is straight. And which one of those 2 you use is going to depend on how much body fat the person has. If a person has a lot of body fat, we find an injection site where the fat is located. We can give it in straight. Even if the person has hardly any body fat, we can still give it subcutaneously accurately if we kind of fold up the skin, like tenting it up and then give it at an angle. We'll teach you that technique. Then there is something also called an intradermal medicine, such as the PPD shot, which you all had, or certain kind of allergy shots that's given very superficially. And hopefully the day that we do this, I'll remind myself to buy a pound of hot dogs. We went through this period of time where we would teach people to do intradermal on each other. Well, that's frowned upon for liability reasons. But then if you have a hot dog, it has to have a hot dog with a skin on it. You can learn how to do intradermal injections that way. So if you happen to view this the day before we do the lab, send me an email reminding me to buy some hot dogs. Okay, intradermal medicines would be like for PPD or for allergies and that kind of stuff. Back to that. Subcutaneous medicines, and the prototypical subcutaneous medicine, which are guaranteed to give, is subcutaneous insulin. It says insulin and heparin. People use Lovenox these days instead of heparin, but there are 6 possible locations for subcutaneous injection, and you will be required to memorize those. As a matter of fact, we'll probably do this in class every time we meet for a few weeks until we absolutely can say what they are. Anterior thigh, abdomen 2 inches away from the umbilicus or any scars. Upper iliac crest, in the back between the scapula and the spine, but 2 inches away from the spine, or over the triceps muscle on the posterior arm, or I forget if I said anterior thigh already. 3, 4, 5. So that's about right there. When we give insulin, you're going to see a particular insulin device, and we got a bunch of these will pass around. People don't, there's fewer times when a person gets insulin by a vial and syringe these days. They're more likely to get an insulin pen, which usually we'll talk about how that is. If they're getting insulin pen, that usually has such a small needle and a spring-loaded device, so that when you inject it and you squeeze it, it doesn't all go in immediately. It takes 10 seconds to squeeze through this small needle, so you have to leave it in place for a minute or 10 seconds. Now we have, says a question here, you're caring for a patient who has diabetes and kidney disease. We need to make a detailed assessment of administering patients because this patient may have problems with absorption, biotransformation, distribution, and excretion. Okay. Next here, we're going to be talking about IM injections, and specifically these ones are about the sites. This is one more thing you have to memorize. We'll show you in class using a skeleton that we have in various mannequins, but you have to be able to find the bony landmarks to use for reference for determining the site of an IM injection. When we're giving IM injections, one little problem we have is the muscles have arteries in them, and the muscles also have nerves running nearby. And so we have to make sure we give the medicine into the muscle, but that we avoid an artery and that we avoid the nerve that's running nearby. So it's very important to memorize the exact way that you would determine where to actually inject an intramuscular medicine. We'll go over this in class. I think there's videos on this. If you can give it in the vastus lateralis or in B it says vastus lateralis or rectus femoris. We don't use those sites that much as we do with the ventrogluteal or the deltoid, but we'll go over this in class and you can read the description. You're going to actually have to physically demonstrate that you can find these without prompting. It's one more thing to remember. When we are looking up an intramuscular medicine, and we look at it in the drug book, certain intramuscular medicines have pigment in them, which will squirt back out the injection tract and cause a small tattoo, or else which are kind of irritating and painful when they're fine in the intramuscular area, but they're irritating to the subcutaneous layer. And so for when we have those, we have what's called the Z-track technique, and we'll teach you the Z-track technique as well. I'm not going to go into as much description of it right now. We're getting closer and closer to the end, but we've got 20 more slides to go, I believe. But we'll be talking about Z-track method in the lab when we get there. And as I say, the bottom line is when we have the medicine, the pharmacy will send a note saying Z-track this, or we look it up in the drug book and say Z-track is recommended for this medicine. Now, if a person has an allergic reaction and carries an EpiPen, we talked it seems like days ago, that we discussed the idea that a person can have an allergic reaction either to a medicine or to a bee sting. And if they're allergic to bees, for example, someone will have them carry an EpiPen in case they get stung by a bee. And this is what an EpiPen looks like. And a lot of times the patients learn how to give them themselves. But if you happen to give one, you should tell people where, you should document which site you use. Now, We do have to mention the intravenous route of administration. We are setting the stage for future semesters where you will, in fact, be more associated with IV medicines, but you aren't there yet. Some people, there's widely varying skill level and awareness level in the class. If you don't know how to evaluate whether giving the patient 2 aspirin helped them or not, then that makes it complicated in case you give them an IV, which can have immediate fatal side effects. We have to be good at doing side effects. We have to practice being really good at physical assessment of the patient we have for all medicines, because especially when we're giving IVs, if we don't know what the medicine does and what we're looking for, then we're just asking for trouble. Now, IVs can be used for like giving antibiotics, in which case you might put it in a small bag and administer it in over an hour-long period. And now, even though it's an antibiotic, they can have systemic side effects like seizures or whatever. But then when we get to the point of giving IV heart drugs and stuff, if you give it improperly, you can stop the person's heart, which it's like, oh, we need to know how to not do that. So this is, and I can't emphasize this enough, we will not be using this route. You can observe the nurse doing this. If the nurse says to you, oh, I've drawn it up, here's the IV, I want you to give it, you tell them that Mrs. Cindy Dubbs will make your life difficult if she finds out that you actually did it. And no, ma'am, I'll watch you while you do it. A very important bottom line thing. Okay, and this is just another way of doing this. When we have an IV site, we need to make sure that it's in the vein and not fell out of place, and that the vein is not infected in some way or irritated. So even though we're not doing IV meds, that doesn't mean we can't examine where the IV is to look like whether it's okay, and we'll show you how to do that. Okay, so now we're doing a bunch of things. We're getting close to the end, but we're also still talking about ADPI, and we're on implementation and evaluation. After you give the medicines, you observe the person to see if they worked. You have to know which questions to ask in a general way about medicine effectiveness and adverse effects, and in some cases what the lab tests are. And then if you notice that there's something wrong or unintended, then you check back with the doctor and say, oh, your patient has this or that. What do you want to do? That's kind of the collaborative interaction between nurses and the doctors that we spent time talking about. Now, I don't know how we got back here on oral medicine administration. We used the 6 rights, of course. I thought we already talked about oral administration. Okay, there's a few things about delegation. That's where we're going with this. We've talked about delegation since day 1 of this semester, and we said nurses work with doctors, but they also work with nurses' aides. You are the one who gives the medicines. You never hand the medicine to the nurse's aide and say, I'm busy, go give this ampule of pills to Mrs. Smith, and I'll chart it later. If you do that, you can lose your nursing license and you'll get fired from your job. That is a no-no, because we're teaching you all these assessment skills for a reason. So but that doesn't mean you can't tell the nurse's aide to come and get you if there's a problem. Like, for example, person is on insulin. We're going to give insulin so that they can metabolize their food. You should tell the nurse's aide, Mrs. Jones gets her insulin, so she has to eat her breakfast. If she doesn't eat breakfast, she might have hypoglycemia. So when you're done giving her breakfast and you take the tray, double check to see if she ate it all and come and get me if she didn't. That would be an example of a way to work as a team so that they're helping you to make sure that you're giving the best care. We can tell the nurses aide things we want them to report to us so we can investigate, because we're going to have a lot of details we're keeping track of. All right, next thing here is, this is about the 50th one here where it says the 6 rights of medicine administration. Close your eyes and say out loud, what are the 6 rights? Do it. Oh, that was so good. We're doing with inhaled medicine. And what ends up happening is sometimes people will be allowed to have their metered dose inhaler with them. Sometimes what will happen is respiratory therapy gives all respiratory medicines according to hospital policy. But they should still work with you as to what. We want to check the person's symptoms and vital signs before. Then we give the treatment and we check the symptoms, person symptoms and vital signs. Okay, so now, and this is kind of the repetitive part. 6 rights of administration for injections. All right, so next is reconstituting medicines. The idea is, if possible, we mix medicines to minimize the number of shots the person needs to have. Or sometimes if it's IV, we have to time the medicines in a certain sequence or take other things to make sure we're not having reactions due to incompatibility of things. Still on delegation. Now, insulin is another one where and we're really getting to the end of this here, but if the person has questions or the person hasn't been eating, then we need to make sure everybody who might be involved in the food for that person works with us, because we don't want to give insulin to a patient who has not been eating, because then we'll bottom out their blood sugar for sure. And that's a complication we want to try to avoid. All right, so generally other aspects here. I'm going to go quickly through these, and I think we're within just a few slides at the end, and these kind of do get repetitive. Do not delegate medicine administration to everybody. You bring the med into the room somehow. Stand there while the patient eats it in your presence. If the person says, oh no, just put it over there and I'll get to it, don't trust them. Use your best persuasive skills to get them to eat while you do it, because you don't want to come in 2 hours later and then the person hasn't taken them, or worse yet, someone visited and the dog took them. That kind